Good afternoon, everybody, and welcome. My name is Paul Helft. I'm the director of the Charles Warren Fairbanks Center for Medical Ethics. It's my pleasure to welcome you to our lecture series, which we host once a month. And it's a great pleasure to introduce to you three of our own esteemed colleagues who are going to deliver the following lecture and session today. So I'm really excited to hear about their work. We record and broadcast these lectures in real time, and then we store them on our website. So you're welcome to go back and look at any one of our lectures through fairbankscenter.org. I'd also like to thank everybody for joining us from Ball, Arnett North, and West Hospital. If everybody would mind taking out their devices and shutting them off, that would be great. There are no relevant conflicts of interest to disclose, and it's my pleasure to introduce the speakers. First is Dr. Mara Nitu, who's Section Chief for Pediatric Critical Care at Riley Hospital. She is passionate about quality improvement initiatives, working toward the creation of effective models of critical care delivery, is actively engaged in promoting the ethical delivery of pediatric critical care, and has been around for a number of years, although I couldn't cite the number, 15. I knew you didn't mean 50. Dr. Vinit Patel is a graduate of SUNY Upstate Medical University, where he completed his internship and residency before coming to Riley to complete his fellowship in pediatric critical care. He's a member of the division. His interests are in simulation education and ethics intensive care, and he's been here for 6 years altogether on the faculty. And then my close colleague, Dr. Lucia, Wocial, who's the nurse ethicist for IU Health at the Academic Health Center and runs the program in nursing ethics at the Fairbanks Center for Medical Ethics. She currently co-chairs the Ethics Consultation Service at the Academic Health Center for the past few years. Lucia, you've been here for, I think it's 9 years altogether, and her research expertise is in the moral distress of professional healthcare providers, so it's a great pleasure to have you. I'm looking forward to your talk. Thanks.
Okay, so the first beginning part of this lecture, I'm going to kind of go over why we did this lecture and then hand it off to Dr. Wocial and Dr. Nitu, who will explain what we did as part of this project. Just a little bit of background. About every year, about 80 children die in our pediatric ICU. In more than 80% of those cases, death follows an extended illness with multiple hospitalizations and or extended time in the ICU. Because of this, medical and nursing leaders were concerned about the perceived high levels of moral distress in our staff. So our review and experience of the literature suggested that delayed initiation of open, honest discussion about limiting aggressive life-sustaining interventions might be contributing to the feelings that procedures and treatments were adding to either patient suffering and higher levels of moral distress in our staff. This was particularly true when caring for patients with extended length of stay and patients who are at significant risk of death or significant impaired functional recovery. Oftentimes, these were patients that required long-term dependence on medical technology, such as tracheostomy and or ventilators. To address this concern, we designed a practice innovation project. And this presentation will present this evaluation of this practice innovation project. Specifically, we evaluated the impact of this project on staff and on the target patient population, which were patients with extended ICU length of stay. So I'd like to give some acknowledgements to some of our co-authors. First, Dr. Vita Ackerman, who was instrumental in planning this project and its implementation. Dr. Brian Bennyworth and Dr. Leland joined this project midway. Dr. Bennyworth was in command of the statistical methods and gave fresh eyes on the project, which was very instrumental in our analysis of the work. Dr. Leland was an ardent supporter of the work and worked diligently on the manuscript. Dr. Mary Ott reviewed early drafts of the proposal and helped formulate the plan for analysis. And Dr. Tong, Yan Tong, helped us with statistical support. Also like to thank Dr. Ivy and the Values Board for this financial support that made the project possible. So the objectives, the aim of this practice innovation was the exploration of how proactive ethics approach supports healthcare providers, and also increase the likelihood that there would be open discussion about setting realistic care goals. Overall, we wanted to decrease moral distress while improving quality patient care in the PICU. And with that, I'll turn to Dr. Nitu.
So many times when we take care of a critically ill patient, we use the words doing everything. So what's everything? Obviously, that's a picture of a critically ill child attached to lots and lots of technology. And we can do everything. We can find a piece of technology that can support pretty much every organ failure. And the pitfall is that so many times we forget to see the big picture, and instead we are concentrating on the scientific approach of how to fix each and every single organ failure, forgetting to look at the big picture and see where are we really going. That perception of forgetting to see the big picture, it's felt by the family many times, it's felt by our nurses, and by our support staff. As a physician, we spend far, far less time in the room with the patient. We are not there to watch the patient for every single move, every single experience that they go through when they receive aggressive intervention. And our nurses, I think, are the first that are feeling the moral distress simply because they are with the patient all the time. So even though we may have a medical evaluation that would state that perhaps the child is not likely to survive the critical illness, we may be slow in approaching that into an open conversation. So avoiding delaying discussion leads to unnecessary additional medical intervention perceived as unnecessary suffering for the patient, and it's associated with increased moral distress. And these are all proven in various published works, and those are some of the citation of those works that have demonstrated that in the past. So how should we frame the discussion when we are approaching with a family an end-of-life discussion, or a discussion to try to reset the expectations to where we have more realistic expectations? We have to realize that it's impossible to follow all paths at once. And we would be important to state that we are very devoted to take care of your child. And it's very important to state that we are devoted to do everything to minimize suffering and pain. But then when we get to debates about offering an excessive intervention like ECMO, high frequency, it's important to think through and make medical recommendations whether or not those are indicated for the patient, and whether or not they are going to benefit the patient. It is very important, the family goes through significant stress and significant suffering when they go to this point. And it's important that we don't make them feel that they have made the choice of letting the child die. And whether you frame the discussion as, is it okay with you for me to not do those things, versus my recommendation is that we are not going to do those interventions. It's a very different moral burden that we place on the family when we phrase it as, is it okay with you? Sure, it's not okay with them. Sure, they want to have a healthy child. But if my recommendation is that this is where we are and these are the extent of the intervention that could benefit your child, it's a very different position that we place the family in, that would make them parents and not really care supporters, and then will help them make the right decision for their child. So setting limits we could withhold specific measures that are not and not initiate a certain intervention. As an example, we would withhold intubation in a patient with CF who is, suffers of end-stage disease. But I would say better examples in our world come from considering not to offer really aggressive interventions that are not standard of care. So, as an example, ECMO. We could provide life support, prolonged life support with ECMO, but that should only be used in the circumstance in which there is a way for the child to actually recover from the illness and then return to their baseline function. Just to support and prolong the life, the dying with ECMO would not be a good idea. And it is within our medical education and our rights to make the decision whether or not those aggressive interventions are necessary or indicated, and simply not offer those aggressive interventions. So there is no need for every child for us to go in and say, oh, I could do ECMO, but I don't think it's indicated. No, if you don't think it's indicated, it's okay not to offer it. When it comes to withdrawal, that requires a conversation with the family, and the meaning of withdrawal is you withdraw specific measures that are already in place. We could withdraw blood pressure medication infusion. We could withdraw the ventilatory support. We could withdraw the dialysis support. And those are discussions that we have with the family when we are approaching very negative grim prognosis and we feel that the care we are providing is now futile. It's important to stress the fact that do not resuscitate does not mean, DNR does not mean do not treat, it means do not resuscitate in the case of a code event. And I think one of the most important pieces of information for us as physicians came in about 4 years ago when Pediatrics published a manuscript stating that if we feel that conducting a CPR, providing chest compressions and resuscitating the child only prolongs the dying process, we can go to the family and say, I am not going to do this because I'm just going to harm your child, and stop the resuscitating efforts. Now, as a nurse, the policy of our hospital is that you are obligated to initiate CPR when you walk in the room who requires CPR, but once the physician comes in, we can say to the family, this is not indicated, it's going to harm your child, and we are not going to do it. It's very hard to do that. So ethical obligation when it comes to an end-of-life discussion would be to be truthful, to concentrate on avoiding harm, and to try to concentrate on defining the word everything, as in everything to provide comfort and alleviate pain. So American Academy of Pediatrics in '96, and then a Choosing Wisely campaign, which was launched in 2014 in critical care literature, states clearly that setting limits on interventions for terminally ill patients is ethically appropriate, and it's a matter of clinical judgment. And I would add clinical consensus, because none of those decisions are one individual decision. Those are reached always in a team approach. I think I'm going to let Lucia continue from here.
So, hang on, I'm trapped. So when we talk about moral distress, this is a definition that I use frequently. It's sort of a long-winded version. When I explain to people in short terms, moral distress is, it's an experience that you feel. It's the feeling that you think you know what the right thing to do is, but something or someone keeps you from doing it. One of the things that's important to understand about moral distress is I may experience it, and I may be actually wrong about it. In other words, what I think I'm supposed to be doing, I really don't need to be doing, or in fact, what I'm doing is ethically defensible. But when I'm experiencing it, when I have that doubt, that's my experience. That's moral distress. Moral distress is a big problem because we know that people who have high levels of moral distress are more likely to leave not just their job, but their profession. The bulk of the work about moral distress was in nursing literature, but there's a growing body of work, including our work, where we stretched to other disciplines that demonstrate this is a problem not just for nursing, but it's a problem for other professionals as well. So when we talk about perceived inappropriateness of care, this was a study that was done when clinicians feel that the care clashes with their personal feelings or their belief. It's most often due to disproportionate care. In other words, we are providing aggressive life-sustaining treatment when we don't feel a patient can survive. And I tell everybody who will listen that ethics is more than death and dying, but death and dying is one of the hardest things that we do as healthcare providers, and certainly the bulk of requests for assistance from our ethics consultation service are cases that involve life and death experiences. So it is invariably associated with factors that have something to do with teamwork. So as we thought about our project, we were also thinking about not just moral distress as it relates to patients, but as it relates to how we work together as a team. Pavlish and colleagues did some work where they identified how you can identify situations where they are at risk for ethical conflict. And I would argue that probably each of you could tell me situations where they're at risk for ethical conflict. Let's say there's conflict within a family. That may be the patient risk factors is, oddly enough, developmental disability, both in pediatrics and adults, is a risk factor, most likely because those patients cannot speak for themselves. And so somebody's always speaking for them. It's always a surrogate who makes a decision about them. Family risk factors and patient not speaking English, so English as a second language. Conflict within families, families who have very strong beliefs in terms of religious beliefs. Healthcare provider team risk factors, discord among members of the team, and certainly in an ICU environment, it's very rare to have just one clinical service consulting on a patient. So when you have multiple cooks in the kitchen, that is an opportunity. And then system risk factors are where people don't have resources to tap into getting ethics support, and or there isn't a good, there are no good structures and processes in place to support teamwork. So when we look at the innovation, I will say nobody wanted to come to ethics rounds, right? And when I work with fellows and we do ethics consultation, I warn them that when people see me on the unit, the most frequent response is, uh-oh, right? It's true. I've come to accept it, and I usually introduce myself and say, nobody's in trouble. So part of the fun part of our project, early days, was coming up with a name that would describe what we do, as well as make it possible for people to embrace it and name it and then go with it. I have a recollection that I came up with an acronym that spelled puppies, but nobody liked it, and I can't even remember what it stood for, so we ended up with PEACE rounds. So PEACE is Pediatric Ethics and Communication Excellence. So a name really did matter, and once we came up with the name, it really took off. People started to talk about it. We still refer to it. Part of what we looked at is there has been some work in proactive ethics where if you can embed a clinical ethicist with clinical teams to get them to meet regularly, that there is a benefit for patients, there's also a benefit for these teams. And then we also talked about how important it was for consistent mentoring from senior intensivists. I remember one of the early conversations with Dr. Ackerman and Dr. Nitu. It was about why do we have to attempt 3 times to see if this child can live without a ventilator? Why do we have to do it? Why do we have to have 3 failed extubations before we have this conversation about do we trach, should we trach, or vent? And so having consistent mentoring provides both guidance as well as support for those clinical decisions, particularly for junior faculty who are learning to stretch their wings. So from here on out, Dr. Nitu and I are going to be doing this round-robin thing. So.
I'm going to describe exactly what the intervention was. So everyone probably here knows the size of our PICU, but for those of us who don't know, PICU in Riley Children's Hospital used to have a total of 34 beds, but of those, about 26 of them were dedicated to PICU patients, and the rest of them were occupied by CVICU patient. Now we have grown and we have more than that. But at the time the intervention took place, we were in the old buildings and that was our bed capacity. In the year in which we've conducted the intervention, we had 1,560 admissions. And we've included in this discussion those patients who were in the ICU for longer than 10 days. And we picked 10 days simply because we looked to retrospective patient data, and we've noticed that those who crossed the mark of 10 days ended up having extraordinarily long admissions and with very many readmissions. So we felt that those would be the patients that would be more likely to trigger moral distress and more likely to have debates regarding best approach in medical care. So that's how we chose the 10 days mark. However, we've allowed to include in the discussion those patients that were felt by the medical team to lead to moral distress. So often either the charge nurse or the physician himself would bring up, oh, I would like to discuss this patient as well. Even though patient has just arrived and has been here only for 3 days, we just feel that we are at a crossroad and would be nice to discuss it as a team. So we invited all, it's really truly a multidisciplinary meeting where we invited nurses, respiratory therapists, chaplain, child life, music therapy, social work, pharmacy, care, discharge coordinators. Every member of the medical team is invited to attend this meeting. The meeting takes place always at the same time, 2 p.m. on Tuesday. And we chose Tuesday because our schedule changes the physician every Monday. So we felt that the physician would be better acquainted with all the problems in the unit by Tuesday and would be equipped to formulate a plan, and then would also have time to execute the plan until the week end. Fragmented medical care in PICU is one of the problems that are actually identified to be leading to moral distress as well. The two intensivists, there were always at least 2 intensivists attending the peace rounds. One was the physician who was providing care, and the other one was somebody that we labeled a senior physician. And most of the times, if Dr. Ackerman or myself, who are the 2 most senior physicians in the PICU, were available and not providing patient care, we were attending as the senior intensivist. But when we ourselves were the provider intensivist, then we had another physician in our group serve as the senior physician. Dr. Patel was had that role many times, and then several other physicians in the group had that role. The idea is not who's senior and who's junior. The idea is really to create a forum in which discussion about where are we going in the long term with this patient, not what am I going to be doing today for the patient, but really what's the plan, what's the big picture. We had more than 80 nurses employed as full-time physician at that time, and this project was supported by all leaders of various multi-specialties in the PICU. These are her tools, and I would do poor service.
I originally asked Dr. Nitu, you can do this slide so there's not so much backing and forth. No, they're your tools. You talk about them. So there are 2 tools that are recognized for measuring moral distress. One is called the MDSR. That's the Moral Distress Scale Revised. The original scale was 38 items, and it asked people to identify the frequency and intensity that they experience moral distress with the 38 stems, if you will, situations. That scale's been revised. It's now cut down to 21 items, which is great. And it actually, one of my colleagues, Ann Hamrick, was one of the principal authors of redoing that. And the idea is that scale really looks at cumulative moral distress. So it's sort of chronic moral distress. The MDT is a moral distress thermometer. It's a tool that I created, and it's meant to measure acute moral distress. And if you've ever had anybody ask you about your pain, you understand how the moral distress thermometer works. Here's the definition. How much do you have on a scale of 0 to 10? So we use both of those tools to measure. The MDSR was done before we even started peace rounds, and then post at the end of a year. The MDT was done every 2 months, even months, to sort of get a snapshot of where people were with moral distress. We created a peace rounds evaluation tool. Basically, were you satisfied? Do you feel like your voices were heard? So a number of factors. And then patient data, we looked at. You're up.
We looked at the 2 metrics that we use frequently in the critical care literature to better define the acuity of illness of the patients on arrival to the ICU. None of them are really strong predictors, but that's what it's used in the medical literature, and those are PRISM or PLOD, and we chose PRISM. And we also looked to PRISM index length of stay, meaning is the length of stay of our patients matching what the literature publishes about expected length of stay on that particular condition with that particular acuity. We also collected data about the code status of the patient, and we collected mortality. We collected many other clinical outcomes, but at the end, we've discovered that the paper was going to be very rich in clinical information and probably too long, so we've narrowed it down to those particular outcomes. I also want to stress that the discussion was not about end of life. The discussion was about what are our realistic expectations for the care of this patient? Where are we thinking the best possible outcome is? And sometimes the discussion did end up going to the end of life planning because the care was deemed to be futile and we didn't think that the patient had a good chance to survive. But really it was about how do we get the patient out of the ICU and how we minimize the procedures that we are doing and how we are going to get the patient with the best possible outcome for the condition that they suffer of. This is you again.
This is so you'll all stay awake. We just keep going back and forth. I also want to point out that this project was about quality improvement for patients. And when we talk about moral distress in this context, it's moral distress because of the patients we're caring for. So this is very patient-focused. So when we looked at, so what were our procedures? We did this initial measurement of moral distress. Before we initiated the rounds, we did the monthly thing. Tuesday piece rounds, we've already talked about. The even months, we have measures to look at that. The 1st and the 7th month, we actually evaluated piece rounds. It's funny, our statistician pretty early on said, you know, your results are pretty much the same. You really don't have to keep doing this. We said, no, we're going to check more than once and make sure that the quality is maintained. And then after 12 months, we did this historical control. So when we look at provider demographics, this is sort of what you see in terms of male, female, overall, and then I have pre-piece, which is more or less the same as post-piece. I elected to have large enough print on the slide for you to read as opposed to squeeze the whole table on there. So I hope you'll appreciate that. But you can see we have clinicians who are a variety of years of experience. 50% of the people who participated in this project, more or less, were, and that's the wrong percentage. Anybody doing math the way that I am in my head and seeing it's not totaling 50% or 100%? Okay, so they were about 50% of people were more than 12 years. So in terms of role, physician, nurse, other, I have to say a lot about other. While you're all lumped into a category, the only reason you're lumped into a category is one of the struggles that we faced is when we asked people to tell us their moral distress, they were a little self-conscious about that. And anonymity was very important to participants. And we could not pull out the data from respiratory therapists, child life folks, without pretty much having you know who you were because you're such small numbers. But please don't take other as you just are all lumped together. We think you're all very important, but that's why we clustered those. So these are sort of our demographics. If you look at, we asked people, so not only did we ask them, tell us what your moral distress is, what factors are contributing to it? And we gave them a list, and people could check boxes and tell us what contributed to it. So clinical situations clearly, far and away, were the most frequent contributor. So physicians and nurses, they didn't have the same, like the same things didn't bother them, but it was sort of important. And if you look at this, the data in the table represents the percent of respondents by role. So we asked people to do it by role, who identified a contributing factor. So not everybody did the contributing factors, but sometimes they did. And when you look at these, the clinical situations, as I said, were the most frequent one. Over the course of the intervention, the range of scores for physicians and nurses narrowed. In other words, people sort of the same things started to bother the same role, if you will. So this, for me, is one of the coolest things that we looked at. This is the spread of moral distress using the thermometer at these points in time. And one of the things that you'll notice, first of all, we looked at this and we were like, oh my God, we don't show a study like people are not, the mean's not getting better. And as we reflected on the data, one of the things we noticed is that there are fewer outliers. So if you look at that very first spike, like that's a big spread there. So there are fewer outliers. What that means is we're addressing the outliers, and those are the people that we really care about. Most of the data about moral distress reports it as a mean. So let me help you understand why that's probably not the most meaningful way to report the data. If I asked all of you in this room, tell me what your pain is on a score of 0 to 10. Some of you are going to be 10, some of you are going to be 0, some of you are going to be 3. Well, the mean is 4, so I'm going to say 4, you're good. Well, all the people with 10 are going to go, I'm not good. I don't care that the mean is 4. I'm still a 10. So what we were able to show over time is we had fewer spikes in terms of people being big outliers. And that actually was kind of a cool thing. We also, when we had a little uptick, we all went back and we looked like, what was going on in the unit at the time? Why did we have this spike? So we mentioned the patients that we included. We did not mention the patients that we excluded. We made a conscious decision at the beginning of the project that we would focus on patients for whom the primary service was pediatric critical care. Our pediatric critical care team supports multiple other services. So if your service line was a primary service, we did not include those patients in the study. But people were still taking care of those patients. And some of those patients are a significant source of moral distress. And when we went back and looked at the spike, all of us could identify 1 or 2 patients in the unit in those 2 months where it was clear that the moral distress would have been high, and they were not patients in our study. So we're not trying to place blame. We're simply trying to explain, because we were all struggling with why was there a spike? What happened there? So when we looked at the patient demographics, this is my name, but it's patient, so you get to do it.
Okay. I think one part we have not explained clearly yet is our intervention occurred during one calendar year, 2012, and our control patients were picked from historical control from the year prior. And we compared the historical control with the intervention year. In the intervention year also, it was one of the slowest year in PICU in Raleigh for a long time. And while we were predicting that we were going to have probably more than 80 patients included in the study, we actually didn't make it that high. However, comparing the control and the intervention patients, there are no significant statistical differences between the age demographic of the patients, nor were significant differences between the acuity of illness with which patients were admitted into the ICU. And the reason for admissions are typical for any PICU in this country, with primary respiratory illnesses, followed by sepsis, followed by cardiac reasons, and everything else is lumped into others.
So I'll also say that while we didn't meet the 80 that we needed 60 in order to have statistical power. So yay, yes. We met the minimum standard for statistical power.
So in terms of the patient outcomes, the PRISM indexed PICU length of stay between the historical control and the intervention showed a significant improvement in the indexed length of stay in the intervention arm, which was one of the things we were hoping to see, not from the corner, not from the angle of we are going to push the patients out faster, but really we are not going to push the patients through so many interventions such that they will require such a long length of stay. And that has been accomplished. There was a significant change in code status, meaning significantly more patients reached a do not resuscitate order in the intervention arm. And I will tell you that when we presented this to a national meeting, that triggered the biggest debate possible.
So it's important when we saw these statistics, if you look at these, one of the headline that we did not want to see is embedding an ethicist in the ICU leads to more death, right? Death in the ICU. This is the epitome of somebody taking this data and using it to say, this is what a death panel looks like. And we were very careful in how we talked about this. While we recognized that one of the potential outcomes of talking about realistic interventions and not providing interventions that ultimately wouldn't have an impact on a child's life and would just contribute to suffering might actually lead to this. So we were a little distressed when we saw that we had a lot more death. And thanks to Dr. Bennyworth, he said, well, let's look farther out. And that was really good news, because when you looked at 30 and 365-day mortality, they were not statistically different. So how we interpreted that, we'll talk about that in the discussion, but this table bears a little bit of, because if you look at that, it'd be very easy for somebody to say, oh, ethics, death, there you go. It's not, that was not the focus.
Yeah, to build more on what you are saying, I really think that the 365-day mortality is the most important number to pay attention to, which obviously has absolutely no statistical difference. And that is because that's the goal of this intervention, to help patients die peacefully and without excessive medical care. Those who will survive have survived that have enjoyed being discharged home. And I mean, clearly, only a third of our patients died. The rest, 70% of them survived, went home, and had a good outcome.
You're probably going to say this, but I mean, another more sort of generous, hypothesis that's generated by these data are that you reached goals of care discussion and a transition away from disease-directed therapy faster and more efficiently, and in the end, in a way that actually reached, positive outcomes for patients.
So I
would look at this generously.
Yeah, so you phrased that very nicely. We'll get you to do that with a microphone later. But that is actually, in fact, how we ended up, and how I would frame what Dr. Nitu said. And, ethics is all about reframing. This is not only thinking about the patients who died more comfortably, it's helping the patients live better. So the patients who survived, they didn't undergo unnecessary...
Or not have their inevitable deaths prolonged unnecessarily.
Absolutely.
But even those who survived did not go through 5 different extubations before we reached the decision of traching them, or whatever medical intervention might be necessary. We just shortened that time and reached a plan sooner. Yes. So when we look to the peace rounds evaluation, there were consistent positive comments, and those are just few examples. But the team has perceived much stronger ability to talk to the families about the goals of care and talk to each other about the goals of care. So when asked if the peace rounds helped participants improve their communication, 85.5% of nurses said yes when they were talking about communication with the family. 95% of the physicians said that they were better equipped to talk to family after the peace rounds. And 96.2% of the other clinical care providers indicated yes as well. And when asked whether or not the peace rounds helped us talk to each other about the goals of care more effectively, 88% of the nurses answered yes, 90% of the physicians answered yes, and 98% of the other group answered yes. And as one who I have been in the peace rounds practically for about every single peace meeting of the study period, it is much more reassuring to go back to the family and present your plan when you know that all the members of the team are in agreement with your point of view, and they understand where you stand, and they understand the goals of care. Because the family may not quite understand exactly what I'm saying, but then the nurse will be equipped and empowered to be able to explain better when I walk out of the room what exactly have I said, and then the social worker would feel the same way, and it's just a team approach that is very, very useful.
I will say there were 2 roles that I played on rounds. One was to ask icky questions, just to push people and say, where do you think we're going? And the other role that I tried to play was call out people who were quiet, who weren't otherwise speaking up. So I took that role seriously, and as a neutral person, not a member of the caregiving team, somebody who didn't have to be present in the unit every day, that was easier for me to do it. And I noticed a big change in, at the beginning of the year, I will say, people were, at the beginning of the project, people were very excited. They would make sure that everybody was in the room, and then people would get busy over the next few months, and they wouldn't necessarily be as diligent, and then I would sort of prod them. By the end of the year, everybody was committed, and everybody was saying, wait, we can't start. We're missing so-and-so, and I know they wanted to come. And so the growth from the beginning of the 12 months to where we ended up was noticeable.
So Lucia asked me to bring 2 examples, patients, one from the historical control and one from the intervention. And please note that those are just patients I picked to match their demographics. So I chose a 4-month-old Caucasian baby in both examples. The one in historical control was admitted to Riley at the age of 4 months old with failure to thrive and respiratory distress, and was quickly diagnosed with Noonan syndrome, but then stayed in Riley for a total of 3.5 months before death. Has never been discharged home from this initial admission. We diagnosed the patient with pulmonary lymphangiectasia, and the patient has been in the ICU in and out for a total of 5 admissions, first one being 33 days long with 24 vent days, and the subsequent ones having a length of stay between 2 to 5 days. And during this time, the patient had 6 OR or IR trips where several procedures were performed, chest tube with pleurodesis, GJ tube, tracheostomy, more chest tubes, more laculated effusion draining, essentially 6 visits. The patient was trached 1 month prior to demise, was never well enough to progress to get to a home vent, had stayed in the ICU on the ICU vent at the end, and the event leading to that was septic shock with belly distension, and us being concerned that this is necrotic bowel with multi-drug support for the blood pressure, and DNR was really reached only few minutes before the patient expiring, and the only thing we've accomplished with that was the fact that we didn't do chest compressions. The child died peacefully at that point in time, but the patient has not been able to be held by the parents, has not had that kind of end-of-life experience that we think it's important as a way to help family have good memories. In the intervention group, the patient was almost 4 months old. He had had RSV pneumonia at 3-week-old, but did not require ICU stay. And now at this point in time, about 4 months old, the patient, 3.5 months old, the patient is coming to the ICU with seizures and fever. And was diagnosed with meningitis. We were able to prove that it's strep pneumomeningitis. And patient progressed to have significant seizures requiring pentobar coma. And after a few days of pentobar coma, we were able to wean that off and weaning the ventilator, but patient did not remain seizure-free and had, somewhat frequent seizures, yet not status epilepticus. And we had a peace discussion in which we'd agreed that we are going to go back to the family and discuss futility of care and end of life, and that happened. And the ICU length of stay, after that conversation, the patient was made DNR, and the patient died, and we withdrew care, and the patient died peacefully in family arm in the ICU 1 day later.
With hospice support?
With hospice support, yes. So considering that moral distress is associated with leaving a position, and we have lots of literature supporting that piece of information, in identifying outliers who have high level of moral distress might be more important than identifying a drop in the mean scores. You've talked about that earlier. And basically going back to the fact that not every patient in the ICU were included in this study. It was only those patients who were primarily managed by the medical team. Those would be the pitfalls of our studies that you chose to discuss.
So we could not link moral distress with attendance at peace rounds. That was one of the challenges of this was a very complicated project, so we couldn't make a direct link. Peace rounds had the greatest impact on nurse moral distress. So we were able to see a significant drop, a statistically significant drop in moral distress on the MDSR, which has those more than 21 items. It was related to communication. And there were other 3 items that were also drops, but not statistically significant. So we felt good about the trend, but we couldn't say it in a robust way, I think is probably the nicest way to put it. We were able to identify, though, people who we asked them pre and post, did you have any ethics education, and what's your experience with ethics consultation? Pre-peace rounds, people said about 50-50 ethics consultation. Post, about 65% said more exposure to ethics consultation. And as far as I know, we didn't have an increase in ethics consults for the pediatric ICU that year. My hunch is that people just felt that ethics was there all the time, so they felt like they had greater support more consistently. Take it?
I think we already discussed this, and I think I should go fast through it to allow for questions. But peace rounds did contribute to decrease the ICU length of stay for patients and led to a more proactive discussion with the families, and we talked about the mortality impact. As final thoughts, we have PICU team has felt strongly that the PICE model is a good model, and we were willing to adopt it as a standard of practice model. And even today, 2016, 4 years later, we are still having PICE meetings every Tuesday, same time. And the attendance continues to be very high without any prompting or reminders. And we continue to enjoy having all the members of the medical team present. And the discussions now, we are noticing, are swinging also towards readmission, towards, oh, this patient has just left, have we missed something? So the discussions are becoming broader and broader. So I think it's a really useful model. And I think we are becoming better team and closer friends with each other by learning how to talk to each other in a more effective way.
I will say that one of the things the grant allowed for is for me to attend weekly rounds for the entire year, and the grant expired, and so I have not been able to attend PICE rounds. It's good for me, and I'm glad to know that they continue. The clinical ethicist hasn't been present, although I have been called a number of times. People said, all right, we're going to talk about this patient on PICE rounds, and we'd really like to have ethics be present. So I am a big believer in being proactive, and I like to think that the team has become very adept at identifying risk factors and seeking resources before they become a conflict, an ethics conflict. So.
And palliative care team is now, since that intervention, right. Palliative team became present at Riley Hospital.
Existed,
yeah.
Existed.
We've built a palliative care team, so they are attending every PICE rounds. And Amy was here as a she's here as a representative of the team.
All right, so we would like to open it up to questions. And I know that since this is being videotaped, we have microphones. I'm going to ask somebody to come down to Paul and ask him to repeat the eloquent thing that he said so that we can capture it. And then if you have questions, please raise your hand and give somebody an opportunity to run to you with the microphone.
I'm old and I don't remember what I said.
Thanks for that.
You are talking about 365-day survival being...
A more generous way of framing your outcomes was that you arrived at decisions with respect to the goals of care sooner.
Yes. The goals of care discussions were sooner. You actually had really eloquent
prolonging the dying process.
That was inevitable. Other questions or comments? I see a bunch of red in the audience, so I'm going to ask the nurses to comment.
We can ask them to comment about their impression if they're not asking questions.
Robin is running up the steps. It's given the blow-by for the people who can't see what's happening.
Thanks you guys so much. How often was the palliative care team involved in these discussions, or were they at all?
So they didn't exist.
They didn't exist.
When we started this, Karen Moody, the leader of the program, was hired toward the end of this. But as she said to me when she was hired, so you pretty much laid the foundation for palliative care to come to PICU. And that's exactly, they literally came in and took over my role, which was asking difficult questions and helping people focus on goals of care discussions.
And they really joined us after the intervention period, so their presence has not colored the actual results.
So if you're not going to ask us any questions, sorry. No, that's okay. While we're waiting for Paul, I am excited to tell you that this project has been accepted for publication in Hospital Ethics Committee Forum. So it's a journal, and it will be, I'm not sure what the publication date is, but it has been accepted. So woohoo. Yeah. Two years.
Much because of your effort.
2 years.
And persistence.
2 years.
So I had a few just random comments in random order. The first is I wanted to congratulate you on really great work. I would challenge you to try to find another ethics intervention that had sustainability within a given unit. There are very few that you'll be able to find. So the fact that this naturally continued without, prompting or further grants or anything is actually a real testimonial to the power of the work. And then in random order, you probably could obtain the timing of DNR orders with respect, how many minutes or days before death DNR orders were written. We did a study on that subject in the adult population years ago and found some interesting findings. It would be, because DNR orders tend to be a marker of a change in goals of care, it would be a way of getting at I don't know if you've already gotten that. And the other,
we have rich data and not the resources to review as much as we'd like. So how's that?
The other thing is, it struck me that the sources of moral distress that were named by the members of the clinical teams that you interviewed are both, exceptionally representative and exceptionally common, especially in intensive care unit inpatient settings, and that they point to, the thing that's almost always at the heart of, these sorts of problems, to name them, about a third of people name, differences in goals of care communication and discrepant views of the prognosis of the patient. And it strikes me that may be one of the real mechanisms that your intervention has addressed.
I think one of the things, and we couldn't pull out everything that we have, but I will tell you that the physicians pre and post identified more confidence in the care that they were prescribing, if you will, and feeling less pressured to do things that were unnecessary. And I attribute that both to the senior intensivists who were present, who were reassuring folks that you don't have to keep doing this. You have clinical data. This is okay. And to the ethics person saying, how many times do you... So I think for physicians to gain that confidence, I think that for me was a big deal. Nurses also identified that. In that respect,
it was a communications intervention. That would be one way, maybe the best way of framing it.
Yep.
I mean, the most famous one that didn't work was the support intervention that was published in 1995, 20 years ago. And it was funded at the cost of $9 million.
Yep.
And it didn't work. It was a negative study.
Ours was better.
Congratulations.
So with $100,000, we were able to make it work.
There you go. Think what we could do with $9 million.
Hi. I'm actually a social worker at University Hospital. Has there been any thought or consideration to apply this to adult world?
Lots of thought, lots of consideration, lots of pursuing of resources to make it possible.
At this point in time, though, it's being considered and strongly discussed to be implemented in NICU. So not just in the pediatric ICU, but also in the neonatal ICU.
So there are a couple of things, and it's my opportunity to celebrate the leadership. This could not have happened without the leadership embracing this. So for us at the Fairbanks Center, the Riley Pediatric Intensive Care Unit was one of the early adopters of unit-based ethics conversations, largely thanks to Maureen Hancock, who that was part of her ethics fellowship project. And Maureen was actually stunned to realize that we took that program and we're offering it all over the academic health center. It was her brainchild. So they participated, and from the very beginning, it was an interprofessional group. That's sort of what, and I spent a lot of time with these folks, it's sort of what set them apart. And over time, physicians listened, and they heard, and they said, okay, this isn't okay. What more can we do? How can we make this better? And so part of, we would love everybody to embrace it, but it takes not just lip service. It takes leaders saying, yes, nurses, you need to get out to this. This is time. It's important. It's physicians saying. So Mara and Vita attended, one or the two of them attended Tuesday meetings every Tuesday for an entire year. And when you work a busy critical care service, and they tapped into Dr. Patel, so it took a lot of commitment for people to show up. And that, and once you get that commitment, then it takes. So if anybody's interested, let us know, and we'll try and figure out how to make it happen.
Or if everyone wishes to hear the presentation, we would love to go to do the presentations for the adult ICUs as well.
Hello, I'm Alex. I'm one of the ethics fellows and a pediatric oncology fellow. I was curious about post-traumatic stress and length of stay in the ICU. I'm thinking about the recent palliative care publication. I think it was from Duke, where their conclusion was palliative care consult in their population didn't improve post-traumatic stress after death of their loved one. Is that a future, area of research for ethics consultations, or is that something we know something about already?
I'm not familiar with the Duke study. I will say that there is a difference between an ethics consultation and a palliative care consultation. Part of what we do is clarify values. When there's conflict, we can address that. I think there's a lot of research opportunity looking at ethics intervention and the aftermath.
What did you mean by post-traumatic stress?
Post-traumatic stress. So, Alex, do you want to?
Where they're saying that they're having guilt and shame about the decisions that their families made?
Correct.
Yeah,
I think complex grief.
Yeah. So families who've had to make difficult decisions, and the Duke study is adult, is it not?
Correct.
Yeah, so it's adults. And Dr. Torkey, one of our colleagues, has done work and identified that there are risk factors in terms of, I don't want to misspeak on her behalf, but there's an aftermath when you've been involved in making difficult decisions. Not necessarily with the support of a palliative care team and not necessarily with an ethics consultation. Just having to make those decisions takes a toll on people who survive. So, is that it? Gift of time, 5 minutes. Thank you all for coming. We really appreciate it.
Thank you. Oh, really? We are ahead? Don't think so.
Oh, my watch is slow.
3 minutes.
3 minutes. Okay,
Yeah.
3 minutes. 3 minutes. Oh, thank you.
I didn't get a chance to write down the actual meeting.
Thanks for your question, Paul.
The piece?
On the wall.
It's going to get published.
Oh, okay. How about we'll give you that piece of paper so you can take it with you.
I mean, you're pointing out graphically representing, not group changes, but actually what happens individually.
Yeah, so part of our challenge is we have some matched data. Like we had people who were matched.
Sure. That would be so much better explained.
It would be a lot messier than anybody thought. Yeah.
You never know. It would be like quality.
See? You did it. Yeah, like, okay. Is that it?
Nurses that will check on when they complain.
No, thanks for letting me do this. This is actually fun for me.
Yeah, this is one of those things where